Conference will now be recorded.
Okay. This is Rick Davis. Today is November 3rd, our first meeting in November. We've got a full house right now, somewhere between about 45 and 47 people, at least 3 newbies, and a bunch of people who have questions. So a quick acknowledgement to our sponsors, Bayer, Johnson & Johnson, Novartis, Myriad, at least for the time being, Blue Earth, Telix, and Foundation Medicine. I'm going to start with the low-hanging fruit for me, which is Mark Nicholson, because we've already done an intake. As Dr. John knows, we did an intake with Mark, and this was in the low and intermediate group last week. And we kind of resolved that this is the group he should be in. There's a couple of things I don't know, so I'm going to ask you a few questions. We'll cover some things before. Mark, how old are you?
65.
65, and you live in Houston, correct?
Correct.
And when were you first diagnosed?
August.
Right. And your Gleason was 3+4, is that correct?
I had 1 4 plus 3. I got my biopsy slides reread by Dr. Epstein. That was quick. And I have 1 4 plus 3. And he also identified or confirmed that there was an intraductal carcinoma, which put me in this group.
That's the reason why we welcome Mark to this group, because we've kind of made a executive decision earlier this year that we would take people with intraductal carcinoma, prostatic carcinoma into this group, because the diagnosis becomes a little more complicated. That's probably all that we need to go into for background, because Mark is in the process of getting more information. That's why he's already been to Dr. Epstein. My question is there anybody in the group who is intraductal tonight, who had an intraductal diagnosis? If so, please put your hand up. Ah, good man. Okay, RJ. You saved my bacon because I meant to call George Diaz and I forgot. Maybe you can, now, of course, he's not metastatic. Mark is not metastatic, RJ, so that differentiates him from you. But maybe you can say a little bit about intraductal and what sort of impact it might have on your treatment decisions, if you're aware of anything.
Yeah, I mean, mine was a little bit of a journey, but I would say when I got the biopsy, I had 2 things. I had intraductal, and then I had large cribiform. And so kind of the large cribiform was the overriding thing, but I think they're related also to my Gleason score of 4+5.
Right.
And so, and then as part of that journey, we got a PSMA PET scan, and that came back with metastases. So right. I think it just will push, kind of, the realization that this is a cancer that might not be messing around, right? So like a 3+4 or 4+3, it's definitely a cancer that you want to get something done with, but it's a little bit more complicated, is a little bit more aggressive, and that might impact some of the thinking that you might have about it, and then some of the treatment decisions and choices that might be made.
Yeah, and just one other question. I can't remember. Have you had a PSMA PET scan, Mark?
My current urologist is going to order one. They haven't called me yet, but I made an appointment today with MD Anderson, but that's 3 months out. That's as soon as I could get in to see Dr. Justin Gregg.
Okay, so let's see if we can get you some help on that. I'll reach out to one of our advisory board members and see if we can help you. But you had, what's the date of that appointment with Greg?
I think it's January 29th, I believe.
Okay. Well, in the interim, and I'm sure we'll be able to do something, but in the interim, what I would recommend is that you get that PSMA scan as quickly as you can, because as you heard, it sort of changed the game a little bit for RJ. I think the big issue and I don't know how much knowledge we have in this group, but by and large, and RJ is an exception because he did have metastatic disease, but by and large, for the intraductal people who don't have metastatic disease, we've seen them navigated more towards surgery than towards radiation, because intraductal disease does not respond as well to radiation, and it's harder to nail intraductal with radiation. Dr. John, you have your hand up.
I was wondering, Mark, when you told us about your MRI, which I know showed nothing outside the prostate, was that an MRI of your pelvis, or was that a whole body MRI?
It was prostate specific, so it was pelvis.
Okay, thank you.
Right. Len or Dr. John, can you respond to Jim Kay in the chat, please? Does anybody here have any input on selecting a treatment or selecting between radiation and surgery with intraductal? Do we have any takers on that one? Okay, Terrell, please go ahead.
I'm just curious, what's intraductal?
So intraductal, and one of the doctors will correct me if I'm wrong, but my understanding of intraductal is that there are all kinds of ducts within the prostate. And when the cancer is found inside one of these ducts, as opposed to in the soft tissue of the prostate, it's considered to be intraductal. And it just makes it more complicated. It moves you up. Intraductal per se does not have a Gleason score. Cribriform does. So cribriform, it's immediately classified as a Gleason 4. And I think in certain circumstances, it can be a Gleason 5. But there's a lot of different types of cribriform. Intraductal does not have a Gleason score. This is something I've learned pretty recently. I think it was when we were working with George Diaz last year. That's what intraductal is. Does anyone else have anything to say about intraductal?
I learned something about intraductal when we listened to Dr. Epstein's talk, and he said
Yes.
that it does not progress to neuroendocrine cancer.
Okay.
So you have a high risk, but there is at least that one little bit of nice news, if it's quite valid. That's a form of of a highly malignant transformation that we sometimes get in our advanced stages.
Is that a guarantee, John?
Nope, I wouldn't say so. We'll have to ask Dr. Epstein that question. Maybe Mark can ask him when he talks. I heard it doesn't ever progress to small cell. But I thought, okay, well, at least there's something good.
Mark N, have you had a chat with Dr. Epstein yet?
I have not. Looking at his notes before the meeting, he did note one of the samples had cribiform morphology.
Okay.
And I'm not sure which one that was.
Okay. Well, one of the nice things about using Dr. Epstein is that he'll talk to you on the phone. In fact, he likes to talk to you on the phone. So what I would suggest you do is send him your telephone number, because he usually does it at on his time, and tell him you'd like to talk to him about your intraductal, and then you can confirm and come back to us and see if Dr. John heard right or not. And you can also ask him about this issue about how intraductal responds to radiation. So that will, that might well be a good place for you to start or continue whilst we're gathering information and seeing if we can get you into Dr. Greg a little quicker. The other thing that I will do is I will connect you to George Diaz, who was diagnosed, I'm thinking, the beginning of the summer, and has intraductal disease and has sort of waltzed around trying to figure out whether he's a candidate for radiation or not. I honestly can't remember where he finished up on all of that. But he's educated himself pretty well.
Okay.
He's in Chicago, so but he's done a good job. And I had the good fortune to meet him at the PCRI conference. Any questions that you have for us?
I guess my main two questions real quick is waiting 3 months with this intraductal. Is that time frame, is that risky? Because I'm not real comfortable waiting 3 more months because I'm hearing this is aggressive.
Well, it's not so much that it's aggressive, it's high risk. And the answer is, for me, I would only want to see somebody at a center of excellence, because I don't think you've been getting good information.
I agree. I'm being the other guy didn't even bring this up, threw up a huge red flag with me.
Right. So, we can send you can go on and keep going with a community urologist, but you're not going to get good information. So you really need to be at a center of excellence. Dr. Alfredo, you're in that Houston market.
Well, that's what I was going to ask. Where do you get your care, generally speaking? Where does your urologist practice?
My urologist is in Tomball at Texas Urology.
Okay. And who's your primary care doctor? Where do you get your primary
Dr. Hamad Qureshi here in Tomball.
And that's a primary care practice in Tomball.
Correct.
Okay. Well, I'll just throw this out, and Rick and Dr. John can help me out here. Personally, yeah. I don't like the idea of waiting 3 months. What I know about intraductal is it's meaningless on its own. You have to know, like, what does the rest of the cancer cells look like? Do they look like high grade? Do they look like low grade? And then, there's intraductal too. So I agree with what Rick said earlier. It just complicates your situation. I wouldn't be happy about 3 months, but Rick and John and Dr. Jack, I have a question I don't think we've popped up here in the group before. MD Anderson today is not just the main campus. There's MDA in Florida, they're in Arizona, there are other places in Texas. Should we counsel this gentleman to go to another MDA location?
Well, the problem we've had is trying to find strong urologic oncologists at MD Anderson. And we know the radiation oncologists well. We know the GU medoncs pretty well, but we have not really done so well in trying to identify the urologists, the urological oncologists, the surgeons. And the starting point, in my view, for Mark should be that urological oncologist, and then they'll guide him to the right place. Now, Howard Walensky recommended Justin Gregg, and Stuart did some research. I did some research, and it seems like he's very solid. So that's where we pointed him to. I'm just not comfortable saying, well, just go to MD Anderson.
Right. And I'm assuming Mark could see Dr. E at Methodist. I'm assuming
well,
he's got the whole metro area at his disposal, right?
Yeah, but she, as you may not have seen, but she's moving on.
Oh, that's right. She's in Portland. Sorry, I forgot. Sorry.
She's not yet in Portland, and she'll be seeing. She will be seeing patients, and I did think about sending him to Eleni, but it's so just a little.
The other strategy for Mark would be, in my case, I saw urologist first and rad-onc second. But is there a strategy here where he could see rad-onc first and urology second?
Well, I'm worried that a rad-onc, even one of the good rad-oncs at MD Anderson, would have a bias, and I just feel like he should start with intraductal. He should start with a urologic oncologist. Okay. It's not, you can do it the other way around if you don't have these complications. But let me reach out to Howard, because Howard said to me, Greg is usually very busy, but if we need some help, that he's willing to send a note to Dr. Greg. So before we get our knickers in a twist, let's see if we can get some help from Howard.
That would be great and much appreciated. I'm not sure if surgery or radiation are my only two options. Is there Tulsa treatment? Is that an option? Is proton therapy an option?
No, well, I would not. No, I wouldn't be looking at any type of focal therapy with intraductal. So,
okay.
Our Ben Nathanson is no longer working with us, but he's also a pretty good expert. So we have George Diaz and we have Ben Nathanson. I'll connect you to both of them, and they'll confirm, I think, and probably can do a better job sorting you out than we can right now, Mark.
Okay.
Any other questions? Because I want to move on, because we've got a full night here.
I don't think so. I've got more questions, and that I just need to go find a doctor. But yes, I'm pursuing MD Anderson unless I hear otherwise. So thank you very much.
Okay, Jeff Markey.
Yeah, well, he mentioned crib reform, and during the UCSF presentation on crib reform, they mentioned that people who had intraductal and almost very high frequency had crib reform as well, and that may be a bigger issue, which surgery makes more sense if it's not outside the prostate, but just something I thought I should mention.
Well, I don't know that. I mean, I've not heard that crib reform calls for surgery. Crib reform is just a morphology of the cell.
Yeah, if it's large crib reform.
Well, he didn't say. We don't know what type of crib reform he has.
Yeah.
And if it's large crib reform, again, I'd have to go back and listen to that video. But we're more focused, not so much on the crib reform, but we're more focused for him on the intraductal. Because crib reform doesn't push him into a high risk group. Intraductal does. So that's the difference.
Well, at that presentation, they said crib reform gives you a 5, but of course it depends on whether it's large or not.
Well, that's right. Cribriform doesn't give you a 5. It depends on the type of cribriform. It gives, is exactly what I said, Jeff. It gives you a 4, and in some instances, it can give you a 5. That's what I said a little earlier. And so we don't know. Now, my guess is that it's giving Mark a 4 because he sent his slides to Dr. Epstein, and Dr. Epstein didn't come back with a 3+5. So I think we could safely say that it's not large cribriform. But that's also why we need, well, we would suggest you have a conversation with Dr. Epstein. We have other Dr. E's. All right, so I'll be in touch with you. I'll do some homework and we'll see if we can get you moved along, but keep coming back to this group for the time being.
Thank you very much, Rick.
Oh, have you had any genetic testing?
It's in the works.
Okay.
I just paid 2 or 3 bills today at a Myriad, so I'm paying for something.
Yeah, but what we're talking about is not the Decipher tests or the Polaris test. We're talking about your germline, if you've inherited anything.
Oh, I don't know. Blue Cross Blue Shield denied my first claim, and my current urologist was going to try and push that through, so I'm not sure where that stands.
Do you have history? Do you have family history?
Yes, my dad had prostate cancer and bladder cancer and died from it. My mom had ovarian cancer. My grandmother had breast cancer. My grandfather had lung cancer, but he smoked and died along anyway. So yeah.
Okay. So the ovarian and you said your mom had ovarian and she also had breast?
My mother had ovarian. My grandmother had breast.
Okay. So right there, you've got a risk going on. And I would be, I think with that family history, you've got to go back to Blue Cross. Did you say Blue Cross?
Yes.
Yeah, you've got to go back to Blue Cross and say to them, and you can call them up yourself, I've got family history. I want a germline test. And they have to give it to you.
Can you spell that for me, please, the test?
Germline, Germline, or inherited. It's another word for inherited.
All right. Thank you.
Okay. So if you call them up and you say to them, and you call them up tomorrow and you say, you're turning down this test, but I got a family history. You know, on my father's side, prostate and bladder. On my mother's side, I've got ovarian and breast cancer. I want a germline test. They're not going to have a leg to stand on.
All right. That's on the list. Thank you very much.
And you can feel free to come back and talk to us, but you definitely need that test. Now, the PROMISE study, which Jeff Markey just put in, thank you, Jeff. If you click on, if you see that in the chat, that's a freebie germline test, part of a clinical trial. They're very close to being closed out with 5,000 people, but you may still be able to get in. So click on that link right now and apply, make an application, and that might be a shortcut so you don't have to fight with your payers.
Okay, which link? There are 3 down here. There are 3 links in the chat window.
It's the bottom one that starts www.prostatecancerpromise.org and goes on.
Okay.
Okay, and that's a freebie test for you, and or anybody else who wants to do a check of their inherited cancer status.
Okay. We'll sit here and get registered as we go through the meeting. Thank you.
There you go. And then what they'll do, it takes them about a week or so. They'll send you a kit in the mail, and you follow the instructions and you send it back. Do not tell them to send results to your doctor. Have them send them to you. and you can pass them along. Otherwise, it's going to delay you even more.
Okay.
Okay. All right.
I think
Yes.
one of us might like to see Dr. Epstein's final report, Mark.
Okay. What's the best way to send it to you?
I'll put my email on it, on the chat.
Okay.
Thank
I am
you.
sorry. Is this Dr. John?
Yes.
Yeah,
Okay.
dr.john@ancan.org.
dr.john@ancan.org. Okay. I was off on another window, so I could hear your voice, but I wasn't looking at the screen. I just recognized your voice.
Okay,
You
guys,
got it
we're
right.
gonna. Okay. All right. I'm gonna keep moving here, and we're gonna go to Gary, I think it was, who was the other new gent. Gary M.
Yes.
Hello, Gary M.
Yes. Can you hear me?
I can hear you. How did you find us?
Maybe through PCRI.
Okay.
Found the links, entered my email, and I've been sitting in last couple of weeks.
Okay. When you say sitting in, you're talking about watching the recording?
Yeah, I watched one of the meeting recordings, and I think I sat in the last Tuesday meeting.
Okay. Okay. Well, sorry if we missed you last Tuesday as a newbie.
That's okay.
How old are you, Gary?
71,
Okay. And where do you live?
Louisville, Kentucky.
Okay. And when were you first diagnosed?
June 6th this year.
All right. And what was your Gleason score and your PSA level?
Initial PSA was 62. Gleason 5+4.
Okay.
11 out of 12.
Okay.
Cancerous.
And you certainly are in the right group. Where were you being treated?
The University of Louisville Brown Cancer Center.
Sorry, Gary. University of Louisville Brown Center?
Yes. Dr. Kumar, Kumar.
Okay. And I'm assuming that they did an MRI before they did
Yes.
the, yeah, okay. And how many cores of 5+4 did you say?
There's several. Let's see, I've got a spreadsheet with that information in it here I can open.
You said 11 of 12 before.
Or cancerous, yeah, only
11
one.
to 12. How many 5+4 was the question?
Oh, okay. 1, 2, 3. 3.
3. Okay, got it. And 4+4. How many 4+4?
I don't see a 4+4.
Okay, that's fine. That's fine. I've got enough of a feel. Now, did they then do a PSMA scan?
Yes.
And what did they find on that PSMA scan?
They found nodal in my pelvis, and then I guess in my chest, at least one node.
Okay.
And 2 bone mets, one in the T2, I guess it was, and one in a rib in the back, lower rib.
Okay. So how many spots altogether did they find?
The pathology, they mentioned selected nodes in the pelvis region and one, I guess, in the chest. I didn't get an actual count. I guess that's something I can go back and try to find in the pathology. If it's mentioned in the pathology report, is that indicate it's goes into the count of the?
Well, there won't be a pathology report there'll be a pathology report for the biopsy, but there won't be a pathology report for the PSMA scan.
Yeah, I mean the radiologist. The radiologist.
There should be, but the reason it's important is because your treatment is guided by how many lesions are identified.
Right.
So if we see more than 5, and some doctors will say more than 4, then you go one way. If we see less than 4 or 5, you go another way. And that's why it's very important.
Yeah, I think it's more than 5.
Okay.
And yeah, okay.
So what treatment has been recommended for you? What treatment are you on right now?
Systemic triplet with Orgovyx, Nubeqa, and docetaxel.
Okay.
I've had five infusions, one to go.
So you're getting the right treatment. That's the good news.
Mm-hmm.
You're doing it with Orgovyx and
Nubeqa.
And darolutamide, Nubeqa, which is also very good news because it's probably easiest on your system. So as far as we can see, you're getting all the right treatment. Now, who Dr. Kumar, who you saw originally, was a urologist, correct?
No, he's a medical oncologist at Brown. I saw Dr. Messer he's a urologist that ordered the MRI and biopsy. He's at the university.
So Dr. Kumar's a medical oncologist, which is good. Do you know if he specializes in prostate cancer?
I guess they call it urogen.
Yes.
You know, that.
Yes, very
so
good.
Kidney and other bladder. Yes.
Okay. Genitourinary. We'll put you out your misery. Genitourinary is what it's called. Okay.
Right.
So, and where is that PSA number right now?
Initially it continued on up to 90, and now it's dropped to 0.45 after the 4th, just before the 5th infusion. So it's a deep, rapid response. Is what they're seeing. I'm also consulting with Dr. Kwan at Mayo. I've been up there a couple of times.
Yeah. Well, we are not fans of Dr. Kwan. If you're willing to go up to Mayo, you want to be seeing Dr. Heath. Dr. Kwan is not a genitourinary medical oncologist.
Right.
All right. And he uses some methods that we don't necessarily agree with. He uses antiquated methods. From our standpoint, Mayo is fine, but there's a fantastic doctor there, Dr. Heath. Barry, do you want to say anything about Dr. Heath and Dr. Kwan?
Dr. Heath is wonderful, very informative, very kind, very reassuring, extremely knowledgeable. Dr. Kwan, by and large, treats you through his team. So
yes,
he'll come in for a few minutes and then leave, and you're left dealing with a team member who I'm not sure exactly what their credentials are, but I think Rick is 100% on the money.
Yeah, I saw Dr. Heath's lecture at the PCRI conference, the recording just the other day. Yeah.
She's great. She's lovely, and she's smart. She's great. We don't always agree with some of what she says, but she's certainly one of our favorites. Dr. Kwan, we have a lot less confidence in. So if you want to go up for other opinions, that would be the place to go. It sounds like Dr. Kumar's doing all the right things for you right now. Has he done a bone density test? Has he tested?
Yeah, they did that a few weeks ago. Yes.
And your bone density is good?
They indicated some issues in the lower spine, I guess, some osteoporosis, I guess.
Okay. So are they giving you any bone strengthening treatment?
No.
Okay. So
I'm taking calcium supplements and so
yeah,
forth.
that may not be enough. So you need to open the discussion with Dr. Kumar about whether you need some sort of bone strengthener, denosumab or zoledronic acid. Denosumab can come in different strengths and you can get it different ways, but definitely please open that discussion.
Okay.
Okay. Have you done any genetic testing?
Yes, I've had both the germline and the somatic. They found several mutations. I don't have the listing in front of me. One of them was the TP53. I think there were 5. My tumor mutation burden was 78, like extremely high.
Yep.
They didn't do the MSI. They didn't run the MSI.
They didn't run the MSI. Well, you'll need the MSI at some point, but you're doing great right now. The TP53, was that germline or was that somatic?
That was somatic. They found nothing on my germline, which was surprising. My father had prostate cancer, so I was expecting to see something.
Well, we'd like, when you have a chance and when you come back, and God willing, you'll be back, then we would love to know what the other mutations are that you're running. We're familiar with TP53, very familiar with TP53. So did you have RB1? Does that ring a bell? Or P10, PTEN?
Possibly. It's been a while since I looked at that listing.
So take a look.
I'll go back and double check.
And it may well influence what treatments you're eligible for going forward.
Right. The initial molecular report actually said that the triplet may not be effective, then recommended immunotherapy with pembrolizumab.
Yes.
Pembrolizumab.
Yep.
That was concerning, but Kumar said, well, that was a study of 50 people. So he kind of brushed it off.
Yeah. So, this is again why we'd like to see a really strong GU medical oncologist on your team alongside Dr. Kumar. We can recommend somebody. We can recommend, you don't have to go as far as Rochester. There are people in Chicago, for example, which is quite a bit closer for you.
Yes. Okay.
There's a couple of good docs in Columbus that we could recommend. I think Frank left. I think I saw Frank leave. Otherwise, I'd have him talk about Columbus. But you know, if you keep coming back here, we can set you up with a good doc for a second opinion. The reason they wanted to, the reason they suggested it was because your TMB is very high, but it's, I don't understand why they didn't measure your MSI. That's kind of weird.
Yeah, there were like 56 genes that they scanned. It was a new lab at the university. Yeah, it just wasn't included in their work.
Well, why don't you, again, ask Dr. Kumar if he can run your MSI?
Okay.
You know,
Well, yeah.
Tell him you'd like to know, because it's going to be important.
Okay.
Going forward.
So the original tumor prostate, the genetics of that are still relevant after.
Yeah. I mean, this is I'm going to throw that question over to the all these very smart guys that we have here. But the primary tumor can sometimes be the driver. What's more likely to be the driver in your case is the TP53.
Okay.
And have they taken any biopsies from any of the metastatic lesions?
No, they did. Dr. Kwan did run wet biopsy, CT DNA, and TMB came back as around 5, and they didn't find the TP53.
But he does that with did he do that with Caris? No, he does it with Guardant 360, I think.
Yes. Yes.
Yeah. Well.
So what does that mean, Rick, when a liquid biopsy shows a tiny amount of tumor mutational burden and a solid biopsy shows a very high amount?
I don't know. That's above my pay grade. I don't know. What I can tell you is that they should be able to read MSI. They can't read MSI off a liquid biopsy, I think. They can only read tumor burden, or it might, I'm not sure about that. Or wait a minute, they can't read tumor burden off a solid biopsy. They cannot read tumor burden off a solid biopsy. They need liquid, I think. I don't know. I'm out of my depth. Docs, can somebody help me here? We got 3 doctors in the room. Can any of you help me? Or Len?
Out of my depth I second that. It's out of not my department.
Yeah.
What this basically boils down to, Gary, is maybe pembrolizumab is not something to just disregard. We're just tracking down pembrolizumab as a possible future treatment in case you can respond to an immunological type of a treatment. But right now you're responding beautifully to triplet therapy.
Right.
So it's not pressing.
Okay.
How are you doing with the side effects, Gary?
The initial first 2 infusions, I had a lot of urinary symptoms. It's like I had a urinary tract infection, had to pee every 3 to 5 minutes, painful, strained. Now, my thinking is it was the chemo going to work. The subsequent infusions, it's been much less than the most recent one, really none of those symptoms. Getting more of the fatigue symptoms, which I guess are cumulative as we go along.
Are you exercising?
Yes. I have a stepper. I got on that this morning. Some weights.
Gary, are you signed up for our groups?
I I registered my email and got the email reminders.
Yes.
So how do I get formally into the group?
That's it. You're done. That's all.
Oh.
You're done. You're done. I just want to make sure you're getting the reminders. We also have a Men Speaking Freely group. You probably didn't sign up for that, but you can go back in and sign up for it, which is to talk about everything except treatment.
Okay.
And do you have good support at home?
Yes. My wife. We're just newly married though. But we've been attending Gilda's Club. There's a weekly support group for caregivers and patients. We've been going there for a couple of months.
So we also have a Care Partners group that will meet tomorrow.
Okay.
So you can, and it'll meet in this room at 5 o'clock tomorrow. Please tell the wife.
Okay.
And I'll try and track you down. From Gary M, I'll do my best to track you down and see if I can get you a reminder for that. But it's just drop in. She's very, very welcome. You're not welcome to the Care Partners group. I just want to tell you.
Okay.
But she definitely is. Okay. Questions for us?
Yeah, one would be the deep rapid response. Is that indicative of a good prognosis? I think I had read, I've got like 900 pages of dialogue with ChatGPT about, all the issues. But one thing they said was that may not be, it may not hold. They were saying that a more gradual decline generally has a more durable remission, but Quan disputed that and said, I'm in the top 1 or 2% as far as response. And then next steps, of course, I'm going to get another PMSA scan December, January. And then that'll, I assume, help guide the next steps. There's a clinical trial available that after 12 weeks of the ADT, they do either a prostate removal or radiation.
Right.
I'm not so sure that I want to be restricted.
So let me jump in on that one, and then we've got to really move on. Oh, and Captain Jim wants to know if you're a veteran.
No.
No. Okay. So you don't need a clinical trial for that.
Right.
All right. We've known some people that have done the clinical trial with the surgery. Frankly, most of us at AnCan don't think the surgery is worthwhile. At the same time, we do think that it may make a bunch of sense to debulk the primary with that. The only issue is that we know, and the studies have said, that men who have high volume disease don't do as well as men who have low volume disease. And we don't know how many lesions you have, but they're treating you like a high volume patient. If you're sort of on the margin and you've got maybe 5 and we've just taken a more aggressive approach, which is not a bad thing, you still may be eligible. But I would be and who offered you that trial? Was that in Louisville or was that at Mayo?
I got a second opinion at the University of Kentucky also. That's where I first heard about it. University of Louisville has that available.
Okay. Well, I wouldn't even consider it. I mean, but probably maybe 12 months after you were diagnosed, or 12 months after the end of your chemo, somewhere in that period, you can talk with somebody about radiation as an option to debulk, and it may make some sense. It just really depends on how many. Any other questions for Gary, or can we move on? All right. I am going to start to go through the people who have questions, and the first person on my list is Brian Hack, because he was here very early when I switched on.
Good evening, gentlemen.
Good evening.
Thank you. And thanks, Rick, for all your good work, too. Appreciate that. Real quick thumbnail sketch. PSA first indication of cancer was in December 2020. I started the triple play. I call it the hat trick, but it was brachy seeds, followed by 25 sessions of IMRT, and during that time was 18 months of ADT. Excuse me. I was nadir. My nadir was for 18 months post primary treatment was 0.11 to 0.17. But in January of last year, 24, it went from 0.11 to 0.55. I had a lot of scans done. Nothing showed up. PSA finally rose to 14.83. Rick, this is about the time I met you. You sent me to Dr. Rettig and Dr. Kaysen. What is his name? The RO. Kashin. Anyway, you put me on the right track. I appreciate that. Kishan. Yeah. So, but while my PSA was writing, I did have a transperineal biopsy at UCLA, and that was in July 15th, and 20 cores all benign. So it wasn't in the prostate. Finally, August 26th to 24, avid retroperitoneal plus low intake of the left superclav. And so that's when I started on the Orgovyx and enzalutamide. And I had SBRT. Hang on, let me just cancel this. Sorry about that phone call. Can you guys still hear me? Is that all right?
Yes, sir.
All right. Okay. So I was started on Orgovyx and enzalutamide in August, and then finally got my SBR treatment with Dr. Kishan on December 9th of 2024. The ADT ARSI started on September, so early September. By the time we found it, then he immediately put me on that. So everything was pretty good. From he gave me we anticipated 9 months of intermittent ADT, and I responded so well, it dropped like a sack of cement. And with the SBRT, we decided 6 months. Let's take a holiday. So we did. So that was early this year, maybe February. And then, so March, PSA, I'm going to go through the PSAs. March, 0.01.
Just
what do you want?
I'm breaking it at a time. Just give us the bottom line here. What's your PSA now?
That's what I'm telling you. It's gone up 2.5-fold every 3 months. And now it's every 6 months. PSA was October 3rd, 1.1. I had a PSMA PET scan, and now I have retroperitoneal nodes with a SUV max of 26.3 and some new lesions on my iliac, external and common, very low though, like 1.9. So the retroperitoneal is an issue, and I'm not sure the SBRT can hit that. but I have a feeling
And what is your PSA right now?
October 3rd was 1.1, and I'm rising about 2.5 fold every 6 weeks. So I'm sure it's double that.
Okay. And what does Dr. Kishan say?
We actually did chat on the portal, and he said ADT will radiosensitize the Mets, and he thinks that we should do another dose of SBRT. I talked to Dr. Rettig. Let's see, that'll be Wednesday, day after tomorrow, and we'll get his thoughts. But my thoughts right now, my questions right now, I know that ADT and ARSI work very well, but some of the folks here on the call, Len and Jerry, are doing the estradiol, and I'm not sure if that's off-label. That's something to consider. Am I getting close to a triplet therapy, adding some chemo, or I know I'm not quite in the category for the Pluvicto, but I do know a couple fellas on another call who have had incredible success with early Pluvicto treatment or therapy. So I don't know. I mean, I have a talk with Dr. Rettig day after tomorrow, and I just wanted to kind of be prepared. So any thoughts, comments, that might add a little horsepower to my conversation?
Well, my take, I'm going to give you my take, but then I'm going to switch it over to some of these guys who are pretty knowledgeable in the group. My take is that you really have this thing under control. I don't like when they take you off of hormone therapy as quickly as they took you off of hormone therapy after 6 months. I know that there are trials that say that, but just in terms of our own anecdotal experience, we see the guys who come off very quickly having problems. And it's worth doing the time. I don't think you're anywhere close to Pluvicto or even Pluvicto for hormone sensitive, because now you can get it when you're hormone sensitive, and we would assume you're hormone sensitive.
Absolutely.
If it were me, I wouldn't be looking for Pluvicto just at this. I think you're going to do just fine. You've just got to do the time, and nobody wants to do the time. Everybody wants to come off, and if you don't do the time, you don't get the benefits. That's mine. Let's hold your comments and just for a sec. Let's hear from Len and Dr. John and anybody else on this. Maybe Steve R. Larry, I'm going to leave the estradiol for the second. I don't want to muddy this conversation with estradiol just for the time being. Go ahead, Len.
Yeah, Brian. So I kind of agree with Rick. You seem to respond very well to hormonal therapy. Have you been on doublet hormonal therapy?
Yeah, it was enzalutamide was my doublet,
right?
And
okay.
Orgovyx.
And you responded very well.
It
dropped
was
like a sack of cement, you said, right?
Yep. Undetectable testosterone.
Yeah, why not just take the easiest path and get back on that? See what happens.
And SBRT?
Is it in a region where you've already had radiation?
Yeah, it was in the retroperitoneal, just below the level of the kidneys, and that's where my SUV max is the highest, 26.3.
So you need to ask Kishan what's the likely side effects from re-radiating an area that's been previously radiated. That's what I would do.
I'm writing it down.
Yeah. And the one thing that we'll say about, there's a lot of good things we can say about Dr. Rettig, but he doesn't overtreat with hormone therapy. And he'll give you the least amount of hormone therapy that he thinks is required. So if he comes back to you and says, look, I really think you should go on Orgovyx plus enzalutamide again, or Orgovyx plus darolutamide, I would do what he suggests. And he may even say to you, you can you can handle monotherapy darolutamide, but I wouldn't bank on that. I mean, I am not one for skimping on the hormone therapy. I
Copy
think
that.
you really need that as a strong basis.
Copy that.
And be willing to do it. Let's see. If you, Steve R., please go ahead.
I'm one for skimping, but everyone has their perspective. I like to skimp with apalutamide intermittent monotherapy, and I let my PSA fluctuate quite a bit. You just keep track of it on scans, and you just have to decide what your tolerance is for watching your PSA get higher and whether that bothers you.
Good point.
And if it's bothering you, then maybe you want to be more aggressive. If you can allow it to go up and then go back on the hormone therapy, whether it's doublet or monotherapy, and then bring it back to cement, because it's obviously very sensitive, you could probably do that for a long time. I've been doing that with combination SBRT and surgery and things like that for the past 17 years, and I'm still hormone sensitive. I mean, you have to pay attention to it, and obviously everyone's different, but a lot of it depends on your willingness to take the risk that you're going to watch your PSA go up, and as long as you're watching it with scans and it's not getting out of control. I'm one for skimping on hormone therapy.
Well, maybe I should correct myself. I don't have an issue with skimping, but I think that if you skimp on the first time that you're on it, and I don't know how long you did, Steve, the first time they put you on, but I think that the first time they put you onto hormone therapy, whether it's mono or doublet, that you've got to do the time. And that's like 18 months at a minimum. Now,
well, when I was diagnosed, as you know, back in 2000, I didn't have any ARSIs. All we had was bicalutamide or flutamide and Lupron. So the choice then was Lupron or combine it with bicalutamide.
Right.
And I decided to do bicalutamide monotherapy at the time, but just for 6 months.
And my feeling is, and like Steve correctly says, but my feeling is that if you do it longer at the beginning, you've just got more chance of getting a more durable response. That's my gut. But Steve disagrees, and look, he's around 17 years.
I'm not agreeing. I think the data, I agree with Rick, its analysis of the data shows that if you go on the doublet or even the triplet, but the doublet, I mean, there's no good data to say that going on monotherapy and intermittent is going to be better than going on doublet. That data doesn't exist. You have to be doing it on your own and taking a little risk yourself. But clearly, I would agree with Rick in terms of the data. The doublet appears to be better.
Yeah, can I add something to this conversation, because it is pertinent? So what they did was they started me on not Lupron. They gave me a shot of what's the other?
Firmagon.
Not Firmagon.
Eligard.
Eligard. Thank you, whoever said that. So they gave me a shot of Eligard while I was waiting for insurance to kick in they gave me a shot of Eligard, and then I was given about a week later the enzalutamide. Well, my PSA fell from that 14.8 to like 1.7, but my testosterone was going up. It was well within normal limits, and even higher. So they immediately started me on Orgovyx, and that's when everything tanked. So a monotherapy, at least from a PSA standpoint, I responded really well to the ARSI drug as a monotherapy in the absence, in the presence of a totally normal testosterone. So I like the idea because the testosterone, I think Len spoke to this at some point weeks ago, but you know, testosterone does cross the blood-brain barrier, and fatigue and mood swings and all these other kind of side effects that, you know, it's hard to quantify. But I do really think that it's very important to keep that testosterone up if the ARSA will block the receptors as effectively as they did, and that was proven by my PSA drop in, you know,
Well,
below 1.1, something like that.
Brian, we got to move on because
I appreciate you.
Time here,
I just have a lot on my mind, and I'm done talking, so I appreciate you guys.
So I think, you know, the bottom line is you've got a couple of questions for Kishan, whether you can get radiation, and I think you've got a very good discussion you can have with Rettig about monotherapy versus monotherapy with an ARSI versus doublet therapy. And I would take his advice. If he says to you, I really think you should do doublet, I'd do it, because we know that he'll give monotherapy ARSI if he feels it's appropriate. And if you trust him and we know he's a good doc and you've had good experience with him, I would find out what he wants. But I do think that you need to get back onto that again, onto a treatment again. We don't have time to get into the estradiol. That's a whole nother discussion, but it is definitely an option. And there are gents in here who have done estradiol. And maybe some of them will reach out to you through the chat and you can talk to them offline about the estradiol. So, you know, Larry, send him a message. It's very, very hard to see individuals' icons when you got 40 of them on the screen. So
I sent my contact information in the chat.
Okay, thanks a lot. Okay. All right. We're going to go to Dan M now. Go ahead.
Hi. I took your advice last time we met, and I talked to Dr. McHugh, asked him directly, will he take me as a patient, and he said yes. And so he sent me some blood works, which I'll have to do too. And now we have to figure out, do I travel to the city for Lupron treatment, or will my present oncologist administer Lupron, and they'll keep me from having to travel for that. I was wondering, has anybody had the experience of leave an oncologist, then ask them for a favor, like to administer Lupron, and how that kind of turned out?
Okay, well, before that, we have a much more important question.
Okay.
And we were left hanging last time. And the reason we wanted to get you to Dr. McHugh, thank you, was because of the prednisone. What did he say to you about the prednisone?
He said start that right away, and I started it today.
Okay. I mean, as I thought, I don't think he realized you weren't taking prednisone.
Right. So I made that clear to him, and I'm more concerned about my blood sugars. He said, well, if it goes up, he consider darolutamide and as a option to do the Lupron shot. So yeah.
Not as an option to the Lupron shot, as an option to the abiraterone.
I'm sorry, the abiraterone. Yes, you're right. Yeah.
So yes, I think we talked to you about that. But as long as you're on the abiraterone, you've got to be taking prednisone. And we've had guys on abiraterone who have blood sugar issues, and they've managed them. But he's absolutely right. Um, there are a couple of options, I would say. First of all, why don't you see if he can get you, if you can get him to give you Orgovix.
Orgovix.
Orgovyx or Relugalix. Orgovix is the commercial name, because Orgovix does the same as the Lupron, but you take it as a pill.
Mm-hmm.
Okay, I've just put it in. So then you don't have to worry about who's going to give you your Lupron shot. All right.
Yep.
Now, not all the insurance carries it. I can't remember. You're a vet, aren't you? Yes, you are.
Yep. Mm-hmm.
Well, you can get Orgovix through the VA, and Captain Jim, come and talk to Captain Jim tomorrow night. And this is why we've got to get you set up at the VA, because this is the benefit of being dual enrolled.
Right.
Now, unfortunately, what happens at the VA is you can't waltz right in and go and see a medical oncologist.
Right.
So you have to go through the PCP, and then you got to get to the urologist, and then you got to get to the medical oncologist. But Captain Jim knows all those tricks.
Okay.
And we know we can get you Orgovix via the Orgovix via the VA.
Mm-hmm.
So I wouldn't even trouble yourself. You can ask Dr. McHugh if he can get you the Orgovix, and if he cannot get it for you, or your insurance turns you down, we can get it for you through the VA.
Right. And so I continue treating with Dr. McHugh, but get the Orgovix through the VA.
Yeah, he won't have a problem with that.
Okay.
Okay, but first of all, ask him for the Orgovix.
Okay.
Yes. Yeah.
How did I do, Captain Jim?
Very good, except there are, it's in the VA, it isn't one VA. It depends on the region. Some of them do, some of them don't, as I'm finding out.
So, they don't. They won't all give you the.
It isn't standard throughout the VA. It depends on what region you're in, because they operate almost independently of each other at times. So, although a case could be made, so it isn't automatic.
Okay. Thank you for pointing that out. I wasn't aware of it. Do you have you had any experience in New York?
Oh, no.
No. Okay.
No.
Okay. Well, start with Dr. McHugh. And when does your current Lupron shot wear out? When do you need a new one?
I just took it, so I got 3 months to go.
Okay, so you're fine. And just talk to Dr. McHugh and tell him you want to switch to Orgovix.
Okay.
Okay. Anybody else have anything to say to Mr. Moore?
So just to make sure I have this right. So the Orgovix works the same as the Lupron, and all I have to do is just go to the VA. Oh, well. Go through the ropes for the VA.
So the Orgovix works in after the first shot, the Orgovix works the same. It does the same thing as the Lupron. You may be able to get it from the VA, but as you heard Captain Jim say, we're not certain. But you can certainly get it from Dr. McHugh. He can prescribe it for you.
Okay.
Okay.
Right. Yep. I'm good.
Okay. Let's move on to RJ.
Hi there.
Hello.
So quick update is that next week I have my final round of SBRT. So that's for the Mets 7 and 8, which are in my ribs, left and right ribs. So I get that done next week. I'm taking off a week. And then starting the Monday before Thanksgiving, I start chemo, which is docetaxel, 6 rounds every 3 weeks. And so, yeah, and I would say, Gary, it sounds like my case is pretty similar to yours in terms of I had 8 metastases, but it was kind of like borderline between low volume and high volume. And
Yes.
just because of the logistics, I started with radiation. So, and they don't do it both the chemo and the radiation at the same time. The standard of care is not to do that. So you do one or the other first, and then you can go, figure out what you want to do next. So what I'm doing next is I'm taking off a week, to kind of get through the fatigue of the radiation and doing the chemo. And my question is, my broader question is, what should I be thinking about in terms of that? I already asked about in terms of like the cold bath and stuff, and they said we give you an ice bath for your hands and an ice bath for your feet, and that will take care of the nerves. And then also I wanted to ask specifically about this neutropenia and like what the impact of the chemo is on immune system. And I've heard actually from 2 different docs, it's like, well, why not get there's a couple different ones, the plinabulin and also the Neulasta. One, I think you do the day of the infusion, and one you do like the day after, and they're supposed to maybe potentially go together. I did ask the doc about that, and she said, well, because I go to Dr. Schweitzer, but I'm also seeing, his medical assistant, and she said, well, you should only do that if you actually have issues. And so I was just kind of like, well, like if I have issues, then is it too late? And yeah, not for the subsequent round, right? But for this first round, is that something I should worry about and I should try and be preventative? What have people's experience been with that? And should that be something I push for?
So I'm going to defer to people who have done chemo, because there's a whole bunch of people who have done chemotherapy in the group right now, and see whether they did the Neulasta or not. I know that the standard of care today seems to be this pump that they put on your arm, so you don't have to return to get to go back every so often. I think that's Neulasta. Doctor, would one of my moderators like to kick this off? Guess not.
I can't, Rick. I'm not, don't have expertise in that area.
Okay.
Yeah, I've never had chemo, Rick. So
I know, but what has been your experience in navigating other people? Any comment?
all I know is that Dr. Oliver Sartor, claims that he's been treating patients with docetaxel on a lower dose weekly basis rather than the traditional dose once every 3 weeks. And he has found equivalent efficacy and fewer side effects. Can't really comment beyond that.
Okay, that's good to know.
What was what was Sartor's treatment back? Sorry, people are sending me messages, which, as you know, drives me nuts when I'm trying to moderate.
He gives docetaxel at a lower dose, but more frequently.
Right, that's right. Yep. So it's definitely an option. I'd also say you should be talking to Dr. Schweitzer and not his assistant about this stuff.
Okay.
I really think that it's important enough that you've got to be talking to Dr. Schweitzer and not the nurse practitioner or the assistant or anything else, RJ. And ask. Dennis Correa, I know, has something to say, and he has his hand up. So, Dennis.
Yes, I went through my chemo almost 10 years ago now with docetaxel. And at that time, it was kind of, a debate whether or not to get the day after shot to prevent the white blood cells from going down, neutropenia. And so I started without it, but about halfway through my schedule of, I think it was the 6 treatments, and developed fever and high fever, and they put me in the ER, admitted me to the hospital, got diagnosed with pulmonary embolisms, both lungs. So it was a nasty time for me. It was before they came out with the patch, but right after that, I had to drop the dosage down to 60% instead of the full docetaxel dosage after I got out of the hospital, and resumed the treatments with the day after injection. That's obviously had to do over again, which I don't want to do. Is I do the Neulasta, do the patch. That seems to be working for everybody. But it's kind of, I thought today everybody would do it without even thinking about it. Back then when I started with mine, it was a little bit of still debate and open. But I was trying to stay active and exercising and this kind of stuff and going out and so I when my white blood cells were down, I picked up something apparently, and the diagnosis actually was double pneumonia with the pulmonary embolism.
So, Gary M., what are you doing right now with the Neutro? Are they giving you Neulasta? Are you going away with the pump on your arm?
No, I asked about that initially when I was reading up on it, and they said they didn't, by default, prescribe that. I guess my blood counts have not gotten extremely low. So far, so good. Excuse me.
Yeah. I mean, that's good. I've seen them. I have seen them put those Neulasta pumps on the arm from the very first, and then I've also seen them not do it. So I really don't know. I don't know what the standard of care is. Does anybody know if there is a recommended standard of care? Oh, Bob Schwartz. There's another man there. Yep, he just stepped out. There he is. What did they do for you, Mr. Schwartz?
They gave me the shot the day after all the time, and when I got my chemo. And I'll tell you what, it gets better as you go along. The first few ones are the most difficult. In fact, pay attention to what the nurse tells you. She mentioned it to me, and I thought she was just being a little funny. She said they call it the bone crushing shot. And I didn't know what she meant. It was serious. It really is. You don't feel it maybe that day or the next day, maybe take 2 or 3 days, but then you wake up and your joints are so tight and all that. But it does help prevent a lot of problems, and you can get through it. Believe me, you can get through it. It's a little awkward at first, and each time you get it, it affects lessen. Unlike chemo, where the effects are cumulative, this isn't. So it's much better with the shot, much better, and you'll be able to withstand it. Believe me.
Okay, thanks, Bob.
Dr. Alfredo.
Sorry, I was slow to unmute. I mean, my experience, and maybe the other physicians here will agree, it's an art, not a science, and individual oncologists do it differently. So I'd love to say, yeah, standard of care, but I can think just right off the top of my head, a half a dozen oncologists doing things that I would have thought would have been the same. They're not the same. Where they trained, where they come from, what goes on in their region. Maybe then you could apply standard of care regionally, which regionally could mean in our town. This is how we do it in Houston. Maybe not the same in Palo Alto, maybe not the same in Seattle.
Right. So
I think it has official FDA approval for both methods, for both pre-treatment and for treatment once the white blood cells tank. So I don't know about standard of care, but both are approved methods of using it as far as I know.
Yeah.
Okay, and sounds like the side effect is some bone crushing joint issues, and I think that's what they're kind of trying to avoid. So it's just kind of like, well, maybe watch the white blood cell counts, and before you develop pneumonia, hopefully you can get the shot.
That's right. That's right. That's right. And hopefully you get a good sense of humor.
Yeah, right? That's what this whole experience has been ultimately, right?
Oh, RJ, we think you're amazing. I think you're amazing.
Well,
so,
yeah, I'll push for that and say, hey, that's all right. You know, it'll take me a couple days before I get back on the elliptical, and I'll just kick back and enjoy my vacation and go back.
You know, as far as the ice water for your fingers and your toes, I don't know which works better. I mean, we've known people that have gotten the gloves and the I think one or the other is probably a good idea. And the ice caps, they work. Those ice caps definitely work if you want to keep your hair. So, what can I say? Dennis, did you have another comment?
Yes, to counteract the effects of the Neulasta, the bone issues, I had that too, in the clavicle, the shoulder joints, and the recommendation was Claritin. I mean, that's an antihistamine, but for whatever reason, that worked to eliminate that pain.
Yep. Great tip.
Thank you.
Make sure you're long on Claritin. We've heard that many times, and the docs often forget to tell you. And the ones who should, like the nurse practitioner, they should. Yes, Dr. Alfredo.
Well, I had an episode the other day where I was the patient, and it was Zyrtec instead of Claritin. Apparently, an even stronger antihistamine.
Okay.
So,
yeah.
So there you go. There you go.
Yeah, my wife has a bunch of that from Costco, so I bought it, so I know we got it.
Yes, yeah. Oh, see, we've got all our chemo guys chipping in their 2 cents. This is great. I love it. Yes, Bob.
Yes.
Yeah, Steve, I just hope you're not like me. I can't win the lottery, but I can win the one where the Claritin did not have any effect on me. I did take the Claritin. The nurse that gave me the shot, she did advise me that too. So it's like the lottery. It had no effect on me. So, but you look like you're young and healthy enough. It's not going to be a problem for you. Seriously, you'll get by. And whatever difficulties they are, it's worth it. It's worth it very much.
Okay, good. Thank you.
I think Claritin is among the weakest of the antihistamines, right? You're probably better off with cetirizine, or I don't know what the first generation antihistamines, if they work or not.
Cetirizine is Zyrtec, and levocetirizine is Xyzal, XYZAL. But apparently they're among the strongest antihistamines now. And the stuff that we used to prescribe when some of us were in training, Atarax and stuff like that, you can't give those anymore, especially to old people, because Medicare says the fall risk is greater than the benefit of the antihistamine.
Yeah, I was just going to say that cetirizine and Claritin, they're both marketed as non-sedating antihistamines, aren't they?
They are.
Yeah.
Okay. Meanwhile, what about that? What about that 600, RJ? What about that 600? I'm looking for it, man.
It started. I don't know. I have a week off from the whole oncology thing, and I'm back to work. So I'm trying as hard as I
I
can here.
see. It's been going the wrong direction the last couple of days. I'm waiting. Don't take too much time off, okay?
We're buying too many GPUs. The whole world is.
Okay. All right. We've got one more person on my list, which is Tony Fig. And hopefully I didn't miss anybody. So Tony Fig, what's on your mind today?
Just as an update, I had radical prostatectomy and I had a recurrence. Then I had radiation therapy, which was 2.5 years ago. And in August, I started getting blood in my urine, and the urologist did a scope and said that it was radiation, hematuria, cystitis. And the following week, he did a biopsy, and he decided that the biopsy did not show anything, but he couldn't get deep enough tissue samples, and there were some irregularities there that he was concerned about. So he scheduled me with the bladder specialist, one of his colleagues, and that was October 3rd. And they removed during that session 5.5 centimeter raised area of cystitis plus some areas that he had the urologist had cauterized. So I just got the biopsy back on that, and that was all negative. But it's taken a while for the surgery removing the lesions there to heal up, because it was right near on the wall, right near the urethra, and that caused a lot of swelling. So that was causing some problems with urinating. But it's taken a while to completely stop the bleeding, but hopefully that's behind me and I won't be getting any more effects of the radiation cystitis. So that's the update on that.
Are you still bleeding?
Very little, very little. I didn't have much bleeding at all. The surgeon really was fantastic in the procedure, but I just get a little bit of bleeding now. And it mainly is occurring after I do a lot of activity, not physical lifting or anything, but just moving around a lot.
Tony, I was curious, at the time of the surgery,
pardon me?
Tony, at the time of the surgery, was the surgeon expecting it to be bladder cancer?
No, he wasn't. He didn't think it looked like that, but he said the appearance did not indicate that. But
Good
there
for
was
you.
an awful lot of bladder spasms involved with it since the surgery, and that's kind of calmed down now.
Good.
I mean, I'm glad to hear you're a lot more comfortable, but maybe you got to go easy on that bouncy machine of yours. That's what it is. You're too much on that bouncy machine, Tony Fig.
I held off on that for a while.
Okay. So, and there's a good comment in the chat from Gary Martin on for you there, RJ, about the polar, the hands and the gloves. Anybody else have anything to say to Tony Fig about this cystitis issue? Because I know a bunch of you have wrestled with this cystitis. And anyone else? I like the outcome, Mr. Fig.
Yeah. Hopefully it won't recur.
Well, It's 8:06. Have I missed anybody? Because it was a bit of a rough start. Is there anybody that I missed, or if there's anybody who came in late, we can talk right now, or we could even call it a day.
Is your
Anybody
friend
else?
done mowing his lawn outside?
Oh, thank goodness he's gone. Oh my gosh. Yes, Larry.
I just wanted to say that for veterans, if you go to the Veteran Service Office organization at your local VA, they can give you help, in person. Maybe not as good as Captain Jim, but they can guide you through the process.
Yeah.
Well, they can't. I'm going to make a comment that Captain Jim would not, but they can. They're available. Do they? Most of the time, no, because if you speak to the veterans, most of them are not that thrilled with their VSOs. And how do I know that? How do I know that? Because I listen to the people coming into the vets group and I hear them saying, well, my VSO never told me this and my VSO never told me that. And they didn't do this and they didn't do that and they didn't do the other. So, yeah, we know they can go to the VSO. Most of these vets know they can go to the VSO. They don't have the patience for it.
Okay, the VSOs at the Alaska VA, they're pretty good.
Okay, well, we don't have too many people in Alaska, Larry, but we're happy for you. Okay, anyone else? Anybody else that I missed? I see Harry came in late. Larry Fish is here. We didn't ask him. Marlon K, that's not somebody I think I know. Marlon K, are you new to our group? If so, we'll come back to you next week. Marlon? Okay. Well, we welcome you. If you are new, come on back. And Dr. John's in the hot seat next week, so he'll remember that you're there. Okay, I'm gonna say thank you and good night to everybody before we lose all of you. Everybody, you're dropping off like flies. Good night.
Good night.
Rick, I gotta say kudos getting through all of that. Just a few minutes over. Good for you.